So important. I think many of us like to have some data around why we should be doing things. I know as scientists and researchers or academics, we often look for that. And the research goes on and on to show that when we actually have a better understanding of shared decision making, of the role that a patient plays in their health and their perception of illness, then patient satisfaction goes up, their commitment to treatment and adherence to treatment goes up, and their perceived outcomes of care, as well as actual health disparities, actually decrease. So this is why it's so important for us to have that awareness of their health beliefs and identify where there might be gaps between our understanding of their health and their understanding of their health situation or circumstances. So examples of what we see within pharmacy, for example, is medication adherence actually improves when we understand these frameworks and apply them to care. The patient's utilization of healthcare services across the entire healthcare spectrum actually improve. And then healthy decision making around health actually also improves per the research. The other thing that's really important to bring up is the impact that we all know social determinants of health make and health outcomes. But seeing here that often we focus on this 20% at the bottom, which is the healthcare that we provide through direct patient care in the hospital, medically, or even in the pharmacies or clinics that we work in. But really, when you think about behaviors around health, this is 30% of what makes up somebody's entire health outcome. And these health behaviors are complicated, they're dynamic, and they do very much become influenced by cultural backgrounds that people may have. And so we as pharmacists or healthcare professionals in general should appreciate this so that we can provide, again, the most optimal care to our patients. So I'd like us to think about kind of the levels of where culture does influence health. At a large micro scale, we can see that this is where we see how does a patient understand their illness? How do they understand suffering or what is required for healing of their illness? We also have to think about, again, the broad scope of social roles around health and the economic context to health, which we can't really dive into too much today. But what we are going to hear a lot about today is the face-to-face interactions that they have with us and how does health intersect with culture in that way, as well as what Dr. Naseem will dive into is the cross-cultural communication. And what is also a very important topic in this is health literacy. Health literacy, we can talk hours about that, but I find as someone in education, we don't often center this. We center, what's the first line medication? What are the clinical treatment algorithms say? But health literacy really is a complicated phenomenon that does very much influence patients' outcomes. Often when we hear health literacy, we might think, oh, that's just how someone understands their health or the materials that we're giving them around their medications. But really, if we look at the true definition that's provided for health literacy, it's much more complicated. It's the degree that an individual has the capacity not only to obtain, but then process and understand basic health information, and then actually make decisions around that health information. And if we think about all the demands we put on patients every day to manage their medications, to remember doses, to remember numbers, to remember appointments, to follow our instructions, both verbally and written, you can think about how daunting this can be and why we have millions of patients all over the world that really do have very low or limited health literacy. And this is part of why our communication patterns really need to be adjusted. So we're tailoring our messaging, whether that's written or verbal, to the patient and where they are at. So how do we go about eliciting a patient's model of illness? I think this requires us to have a very non-judgmental attitude, a true, genuine interest in understanding their viewpoint before starting to lecture, educate them about what we as the experts might think, to really have a respect, even if we don't understand their cultural values or beliefs or practices, to have a respect for that. And this goes beyond just, addressing limited health literacy, but really thinking about what are the disparities that we see in health in our communities that we're serving? What are the attitudes our healthcare teams have towards certain patient populations, and what biases we might be carrying? thinking about barriers to care like socioeconomic or environmental factors, as well as just simple things like what are cultural food preferences, because we often know food is medicine for many cultures. What are the spiritual approaches to health and illness? What is the role of family and community in healing and ailment treatment? So these are all parts of that kind of cultural construct that we should have in our minds as we approach a conversation with patients, especially if we want to build our cultural intelligence. One of the exercises I do with my students in the classroom is I have them reflect on their own community. I know we often think about externally our patients that are coming to our clinics or hospitals or pharmacies, but what about your own family? What about the own neighborhood that you grew up in? What were the attitudes towards, for example, using emergency services versus preventative services? Who are the gatekeepers of health in our own family? So gatekeepers meaning who was the person that reminded everyone to make their dentist appointment or to take their medications or to go see the doctor for a follow-up visit? Or if somebody was having symptoms, who was that person that was encouraging them to go get them evaluated? What are the values that are put on more traditional therapies versus more Western prescription-based medicine? Often I find in my patients that a lot of them don't want to use prescription medications first line, even if I can tell them all the data and evidence to support the outcomes. They want to use traditional healing practices first. And then also, what are the roles that they see us play in their health and their healing? So the role of a pharmacist changes from country to country, the role of a physician, the role of a nurse. And so it's important, instead of assuming these things, to ask our patients open-ended questions to see how these things play out for them in their own minds. Anthropologists many years ago provided a framework or a model called the explanatory model of illness that really allowed us to further investigate a patient's perception. And they really did it along 5 lines: etiology, the time and mode of onset of symptoms, the pathophysiology of a disease state, the course of sickness, and then the treatment. But what was interesting about this model, although it allowed us to better understand the patient's illness, it was very different than the way we're taught often in our training as healthcare professionals to see illness and diseases. We often learn through these 5 constructs. We learn what causes a disease state, how quickly it might progress, for example, if we're thinking about infectious disease, what are the microbes that might be causing, or the viruses behind a disease, when a patient might be chronic or acute in their symptomology, and then what does the research show us how we should treat. But this is very, very different than the way a patient is approaching us in their healthcare encounters. They're asking themselves questions like, what caused this sickness right now? Why do I have to be sick in this moment while these other things are going on in my life? How is this working in my body? I know, again, going back to the example of infectious disease, somebody might come in with pneumonia and we might be thinking about gram positive, gram negative. They're thinking about, maybe I was outside and my hair was wet and that's what caused me to be sick, or I wasn't wearing enough layers in the cold. And that's their framework or their model for their illness. How do we respect that kind of example without dismissing the patient's perception? They might be worried about what's going to happen to them, or how should I be treating this? Again, going back to traditional therapies, maybe I'm going to pray about my health before I'm going to take a medication. How do we, again, honor these differences in our conversation with the patient? There's really no script for when we're doing this work around gaining cultural sensitivity and appropriate care for our patients. The first goal, again, is always to understand from the patient perception what is going on. And this requires us to really ask a lot of open-ended questions to unlock what the patient thinks first. This is where we can then have a launching point to then further explain and use our clinical knowledge to educate them about what's going on. And again, Dr. Nasreen will talk about some of the models you can use in cross-cultural communication. But I really want just to explore some of the other frameworks around this. One of the big ones that has been around for decades and is very easy to incorporate 1 or 2 of these questions into your encounters with patients is the Kleinman cross-cultural communication tools and interview questions. And so this is open. You'll notice every single question that Kleinman came up with was open-ended. So again, to not have yes and no answers from patients, but rather have them explain. And again, we're here to listen first. So what are they calling their illness? Sometimes I found, even as I manage some of my patients in the cardiology world that I work, I may say high blood pressure, and they might say something very different about what they call that. They might call it my stress syndrome or something else. And I need to understand that that's what that they're labeling their disease state as, or what they think has caused it. So again, stress syndrome, I think a lot of patients with high blood pressure in my practice will say, this is because I have a very high stress job, or my family has a lot of problems right now, or my diet is causing these problems. And again, I'm not thinking maybe from that mode as someone who has studied the pathophysiology of hypertension, but I need to respect how the patient is seeing them so I can better communicate with them. What problems do they think their illness is going to cause? How severe do they think it is? What kind of treatment do they want? And what do they think are the main problems? What do they fear about the illness? And that can be very different than what we see, again, from our biomedical lens as healthcare professionals. A patient might fear having to be on injectables as their main concern. We might be fearing that they're going to end up on dialysis or end up with a stroke or a heart attack. And again, our fears might be very misaligned, and we need to kind of, again, investigate that through these open-ended questions. Some of the other questions I like to incorporate into my interviews with patients is, what is their usual diet like? Do they have a preferred language? Again, addressing that health literacy. What has been their experience with the healthcare system or other healthcare professionals? They might have had, as a pharmacist, many negative interactions with other pharmacists. I need to be aware of where they're coming from as I start to work with them as well. Or if they have restrictions against certain treatment options, or if they have other caregivers or healers that they want as part of the conversation when we're making decisions around their health. The other model I want to talk about is the health belief model. And this is really a decision-making model where it looks at, and this has been around since the 1950s too, so these models are not brand new, but it really shows us where we can understand or, again, unlock the perception of health and how patients go about making decisions around their health. So what the model has shown is that people perceive themselves as susceptible or vulnerable to disease. They're more likely to adhere to treatment. If they see the disease as serious, they're more likely to engage in their health. If they see a benefit that outweighs the barriers or limitations, they're more likely to engage in their health. And as healthcare professionals, I think we can leverage something like this so that we can promote healthy behaviors, disease prevention, both pharmacologically and non-pharmacologically. So I want to give you an example, because I know some of this is very abstract as we hear some of these definitions, and something that we've all maybe encountered the last few years during the COVID pandemic is applying the health belief model to, for example, COVID-19 vaccine hesitancy. There's been many studies that have looked at this, but what they found is that vaccine hesitancy using this framework went up when patients felt the severity or the consequences of actually getting COVID-19 was very low. And we saw this early on in the pandemic as we were rolling out vaccines here in the United States with younger patients that felt like, well, I'm healthy. I don't need the vaccine. My body will take care of things on its own. They also found that the personal risk of getting infected with COVID was high. If they felt that it was high from taking the vaccine, then they were less likely to get the vaccine. And this was, again, some of the misconceptions that were around that people felt early on with the COVID vaccine being rolled out in the United States, that maybe the virus was in the vaccine and they didn't want to risk taking the vaccine. And so, again, education that needed to be provided around that. Again, the benefit to health, receiving the vaccine, people hesitated to get it if they didn't think that the vaccine was going to actually benefit them over harm them. Or there was barriers, so difficulty getting the vaccine, whether it was making appointments to get it, finding a provider that would give them the vaccine, that also increased vaccine hesitancy. So again, we can see this just as an example of how to apply the health belief model to many other situations we might see ourselves in with our patients. And lastly, the concept of locus of control. This is again a kind of a psychological way of seeing the social learning and approach to health decisions a patient might take. So when patients, and the context of locus of control, I should say, changes from disease state to disease state, or what type of treatments we're providing. But sometimes patients might see the outcomes are within their control or not within their control. And this is where getting to ask more questions of our patients really unlocks this information that's very valuable when we're coming to motivating them to make healthy decisions around their health. So when you have a very high internal locus of control, you feel that often you are in control of the decisions around your health. So for example, I'm responsible to make my doctor's appointments. I'm responsible to take my medications. If something happens with my health, it is not someone else's fault. It is my fault. That's kind of an internal locus of control narrative that a patient might have. Versus an external locus of control is that outcomes are beyond me. That this is fate, this is my destiny, this is up to my family to help with. And so, it might be up to chance or luck. Like I've heard this when I provided smoking cessation counseling to patients that say, you know what, I can smoke forever. If God wants me to have lung cancer, I'm going to get lung cancer. And, understanding that where that's the patient's coming from allows me then to pivot how I'm communicating with my patient, because I want to respect that they might have this external locus of control around smoking cessation. And, how do I manage that? How do I not dismiss that as a healthcare professional so I'm culturally sensitive to that situation? So I think this is really interesting because as I've kind of explored questioning patients to see where do they fall on the spectrum of external versus internal locus of control, it's provided with me with more clarity on how to engage in conversation with my patients. And lastly, I think cultural influences on care are very broad, but I think understanding that culture and social influences very much impact how people seek out their health, how they perceive, again, like we've talked about, their illness, how the illness is working in their body and what is necessary for healing or treatment, how they're going to make decisions around healthcare choices. Again, that could be with medications or not with medications, how they interact with the healthcare system. And also, lastly, one of the things that we often don't center, especially in pharmacy education in the US, is the spiritual or religious restrictions that come into treatment options. One of the frameworks that I ran across a few years ago is the HOPE questionnaire. And this is a tool that you can use for spiritual assessment during a patient interview. So this is divided into, what's the source of hope, strength for a patient? Are they part of an organized religion or a spiritual group? What are some of their spiritual practices around health? And what do they feel is the intersection of their medical care and maybe even end of life issues? So these are just some examples of questions from the HOPE tool that you can maybe integrate if you do sense that a patient does really lean into spiritual healing as part of the way they see their health moving forward or illness moving forward. And this can be complicated. Sometimes as healthcare professionals, we feel like this is not something we should talk about. But I think that when we do, I have found that more patients really build trust in us and our rapport with patients really does improve even more so. So I want to just leave us with, the fact that when we try to deliver culturally appropriate care, when we grow in our cultural intelligence, this takes time. Nothing happens overnight. It's with practice and dedicating the time to each patient encounter so that we're building that trust and rapport, and we're listening more than we're talking sometimes, and that we should always think about our learners around us and our workforce around us. Are we providing the cultural competency development? Like you're here today for this webinar, that's part of development. Are we providing this continuously to everyone? And then what are some of the policies and practices we should change in our systems so that we can integrate more of these conversations around health belief frameworks and cultural care in our patient encounters? Thank you so much for all of your attention, and I'm happy to wait and take questions after Dr. Nasreen speaks, because I think she's going to add to my presentation with more of her knowledge and expertise. And again, I appreciate all of your attention today.
Thank you, Dr. Sally. That's, that was a timely presentation and really very inspiring and thoughtful. Do you mind if we take one or two questions? I know you have time, another commitment, so we'll make it fast. First,
Yeah.
Yusuf Hafidi, I guess he's from Morocco. He sent a message that he appreciates this excellent presentation. So thank you very much, Dr. Sally. When I first came, like 12 years ago to Abu Dhabi to establish Cleveland Clinic Abu Dhabi, we were responsible to set a culture of patient first. So from your experience, how long does it take to set a culture or to establish a culture that are a patient-centered approach? What's your experience in this?
I think it depends on leadership. And I have to commend you, Dr. Osama, because I remember meeting you at Cleveland Clinic Abu Dhabi, and I know you made an intentional approach that you wanted all of your team to have this person-centered, patient-centered approach to care. And I think that really helps move the culture forward when leaders are modeling this in their institution. And then, of course, it takes every individual to do the work too, to look inward at where are my biases, where maybe do I need to, even if I've been in practice for 30 years, where do I still have to grow and learn about others? And that mentality is so, so important, I think, when we're thinking about implementing some of these cultural practices in our healthcare system.
So is it matter of several years or months, to set a culture of patients?
Yeah, I think it's hard. I think it depends on the institution, but it definitely doesn't happen in days or weeks. It takes time and intentionality. It's not something you can just write a policy and say, okay, now we're culturally competent or proficient healthcare professionals. You have to do it in your action. And so it does take time to get there.
Actually, we were told that it takes 16 years, to set this culture in our region, in view of, many things to be corrected in our healthcare system. Dr. Sally, I have a question in mind. I put it somewhere, one moment. Yeah, how can the health belief model be used to evaluate the effectiveness of patient-centered cultural care programs, thus in promoting health and reducing health disparities among culturally diverse populations?
I think if you incorporate open-ended questions that come from the health belief model, and there's lots of research around how to do this across different disease states, you can actually embed that into interviews with patients. Then you can start to see the impact of it eventually. Again, it doesn't happen overnight, but I think by just, first of all, knowing what is a health belief model, and then looking at the research that's been done maybe in the space that you're practicing in clinically, and in integrating some of the questions of the health belief model into the everyday interactions, whether that's the first primary interview with a patient, that's kind of how you can start to get some of the data to see who are your patients, what are some of the belief systems that are there, and then how do we navigate around those and help individuals see our lens as well. Because I think we often think only through our biomedical lens, but we have to kind of come together and have that shared understanding.
Yeah, we have a message from Osman Dabida, I think is from Nigeria. Wonderful presentation. And I think with this knowledge, my practice will never be the same again. So he was so much thankful and inspired by your presentation. So Yusuf Hafidi is asking how we can take benefits from this approach, which is the health belief model, on patient therapeutic education, specifically in cancer care. Any ideas, pharmaceutical interventions, etc.?
There are papers, I know, in oncological care using the health belief model, especially as you think I cannot answer the pharmacological interventions, but I know there's non-pharmacological interventions that have been studied around cancer care and cancer patients that would be a starting point, but I can't answer specifically to the pharmacological interventions. I'm not aware of that literature.
No problem. We have a anonymous attendee who's asking, how could patient-centered care model withstand corporate and health insurance obstacles to reduce cost and inflate profit? Is there a balanced approach?
That's a complicated question. That's a good question. And I'm thinking about our audience right now, and I have to speak only from the US lens. I'm not aware of all the different profit models across our audience and where they might be practicing. But I know that we're moving towards more of a value-based rather than a service-based profit approach. It's still very slowly evolving in the United States, but I think when we move to a value-based approach to reimbursement, then that's when you actually see some of this cultural care integrated, because it now matters how a patient perceives their care from the healthcare team. It's not just about providing a service and checkboxing that we gave them medications for a certain disease, but how did they feel about that?
Excellent. Probably last quick question. We still have in some hospitals here in the Gulf region, especially in private sector, that, my physician, my doctor is responsible of my health, with limited, recognition to the support services like the pharmacy, nutrition, etc. What's your advice in this? How we can change this belief?
I think we have to start with our colleagues. I think, as I've developed relationships with my physicians, they've started to become the spokesperson, right, for the pharmacist on the team, the nurse on the team, the social worker on the team, because they have that relationship with me and they see that the value that we bring. So I think instead of pharmacists always feeling like, or nurses always feeling like, or a support team having to always advocate for their voice, I think we have to get some of our physician colleagues to also be champions for the services that we also provide in the models that we deliver care through.
Dr. Sally, thank you very much for your time.
Thank you.
It was a very good presentation. I enjoyed it so much, and we wish to see you with us again at IVPN.
Thank you so much.
Thank you. Thank you. And now allow me to introduce our second speaker before we go into effective communication by Professor Abdurrahim Murad. So let's go to the second presentation by Dr. Nisreen Murad. Dr. Nisreen Murad is a clinical associate professor at the Lebanese International University, where she earned her Bachelor of Pharmacy and Doctor of Pharmacy degree. Dr. Murad has held a research master degree in pharmaceutical biotechnology from the Lebanese University. She has joined LIU from the year 2011 and still. Previously, Dr. Murad was appointed as Experiential Education Coordinator and currently as the chairperson for the Pharmaceutical Sciences Department. In addition, she teaches various courses, among which are the pharmaceutics, pharmacokinetics, pharmacotherapeutics, and pharmacy practice experience courses. Dr. Murad has presented in both local and international conferences in fields related to academia, emergency medicine, pharmacoeconomics, community pharmacy, and health and medicines information. So over the next 25 minutes, Dr. Murad will be speaking on empowering global healthcare professionals through cultural competence. Dr. Murad, I'll leave the mic and the screen to you. And first, tell us about the situation in Biqa in Lebanon.
It's very cold.
Cold?
Not as cold as Chicago, but it feels colder.
Excellent. Excellent.
Thank you so much, Dr. Tabala, for your introduction. So good morning, good afternoon, and good evening for everyone attending from around the world. So the objectives of moving. No. The objectives of today's presentation is to define culture, cultural influences on healthcare, cultural competence and health disparities, to analyze cultural diversity and demonstrate skills needed to be a culturally competent healthcare professional, to identify barriers to effective cross-cultural communication in the healthcare setting, And finally, to discuss strategies to improve cross-cultural communication in order to improve health outcome and patient-centered care. Within today's healthcare system, health disparities have been well documented. So in 2000, the National Center for Minority Health and Health Disparities came up with a definition. A population is said to be a health disparity population if there's a significant difference in the overall rate of disease incidence, prevalence, morbidity, mortality, and survival rate in that population as compared to the health status of the general population. In fact, health disparities have been well documented in many racial and ethnic groups in many studies. However, as I mentioned, they do include differences in rates of diseases. However, they extend to include differences in access to healthcare and thus general health outcome. From a worldwide perspective, the World Health Organization reported a 34-year gap in life expectancy between countries. So in low-income countries, the average life expectancy is 62 years, while in high-income countries, it is 81 years. Let's take an example here. A child born in Sierra Leone is expected to live to 50 years, while a child born in Japan is expected to live to 84 years. As for maternal mortality, it also acts as a health indicator that shows wide gaps between and within countries. If we take the developing countries alone, they account for a total of 99% of annual maternal death in the world. So females in Chad have a lifetime risk of maternal death 1 in 16, whereas females in Sweden risk is less than 1 in 10,000. So those are very important numbers that we need to assess. Now moving on within countries. The Centers for Disease Control and Prevention, the CDC, in its Health Disparities and Equities report stated that in the United States between 1999 and 2008, both life expectancy and expected years of life free of activity limitation caused by a chronic condition was significantly greater for females than for males. Now, if we take diabetes, for example, it was more prevalent among males, those aged more than equal 65, those who were poor or with disability or had less than high school education. Also, diabetes was more prevalent among Hispanic, non-Hispanic, Black, and those of mixed races. Now, why am I talking about all of this? And simply because if we want to reduce health disparities and achieve health equity, we need to improve the cultural competence in our healthcare professionals. So before understanding how to become culturally competent, what is culture in the first place? So Dr. Rafat, please please can you answer the following questions? So what do you think? Culture is influenced by race, ethnicity, language, customs, or all of the following? So we'll take a moment for you to answer and then we'll see the results. I couldn't vote. As a panelist, we cannot vote. So please, can we see the results now? So I guess 90% of the audience already know the answer, which is great. So according to the National Center for Cultural Competence, culture is defined as an integrated pattern of human behavior that include, however, not limited to, thoughts, beliefs, communication, languages, customs, values, relationship, practices, rituals, roles, manners of interacting, courtesies, and expected behavior of a racial, ethnic, religious, or social group. So although the most obvious component of culture are race, ethnicity, and country of origin, however, the concept goes beyond that, and culture can be influenced, in varying degrees, of course, by many factors such as beliefs and languages and customs and values and religion and social group, irrespective of race and ethnicity. And eventually, you'll find out that you belong to more than just one culture. And this will play a major role in shaping a broad range of perspectives toward health and beliefs and behavior. But how does culture influence healthcare? And it does influence a patient's health belief and his perception on disease and treatment. In fact, culture defined health and was considered to be a health problem. For some culture, health is a harmony with Mother Earth, or as a connection between mind, body, and spirit, or as a balance between hot and cold. So I'll only cover a few perspectives because definitely we cannot cover everything. Also, culture defined illness, disease, and how they came up or what their causes is. For some culture, diseases are punishment for sins or as imbalances with natural forces. As for symptoms and how they're expressed, a very important example here would be mental illness, because for so many cultures, it's considered to be as a stigma. So patients from this culture, they often report their symptoms as somatic complaints. So they tell you, I have generalized fatigue or generalized weakness or all over pain. Sometimes they don't express anything and never seek psychiatric care. Moving to attitudes toward healthcare professionals, for some cultures, healthcare professionals are authorities who are responsible to make every single decision regarding their health. For others, no, they're only responsible to diagnose, prescribe meds, and give meds. Whereas for some culture, they don't even trust us. Now, as healthcare information is received, it's important to know how to communicate with your patients. Because for some culture, family members won't permit discussion of serious health problem with patients themselves. For others, it's considered to be disrespectful if you directly address your patient and look into his eyes. And on the contrary, some cultures believe it's super important to develop and maintain personal and trust relationship with their healthcare professionals. Finally, the type of treatment given will be affected by culture because many of them employ traditional healers, folk medicine, complementary alternative medicine, and so on and so forth. So you need to take all of this into consideration. For those reasons, if you have patients the same age suffering from exactly the same disease, it doesn't mean they have similar health belief. As such, we cannot approach healthcare in similar manner. So why do we care about that as healthcare professionals? And as healthcare professionals, we do have a broad range of responsibilities toward our patients. And our commitment to provide them with optimal pharmaceutical care would be incomplete if we did not incorporate the cultural influences in our patient's life. What do I mean by that is definitely we need to be clinically competent. We need to select the most appropriate first-line therapy, diagnose your patient right, know the drugs, mechanism of action, side effects, contraindication, dosage form, and so on and so forth. But at the same time, we need to be culturally competent. We need to be able to act to effectively work within the context of culturally diverse population. We need to understand how an individual culture can affect their healthcare choices and treatment outcome. So as healthcare professionals, we need to take all of this into consideration when interacting with our patient and developing drug therapy plans for them. So shall we strive for cultural competence? Definitive yes. What is cultural competence? According to the Office of Minority Health, is a concrete set of behavior, attitude, and policies that come together in a system, agency, or among professionals to enable effective work in cross-cultural situations. Another example define it as being able to recognize differences, identify similar pattern of responses, avoid stereotyping by acknowledging variation, and balancing our occurring action. In fact, cultural competence in healthcare require proper knowledge, skills, and attitude needed to establish adequate understanding of patients from diverse culture and background, enabling us to provide patient-centered care. In fact, cultural competence is a journey and a developmental process that evolves over an extended period. So a continuum illustrating different levels of cultural competence have been described by Cross et al., starting with cultural destructiveness. And here, individuals devalue cultures through various aspects such as attitude and policies and procedures and practices. In culture incapacity, here individuals make biased decisions and disseminate stereotypes regarding others from different cultures. Moving to cultural blindness, here individuals provide services with a philosophy of no bias, assuming that one size fits all. So if a system works for one, it should work for others. In culture pre-competency, here it's different. Here individuals desire to provide high quality services to patients from diverse culture, but want to do this with minimal changes. We already discovered and we talked about culture competency, so we're left with culture proficiency. And here culture would be integrated into leadership and projects and publications and research and new approaches to care. As such, teaching cultural competence is vital to transform students into future practitioners who can provide true care for increasingly diverse patient population from different backgrounds and cultures. As such, it has been at the forefront of pharmacy education for several years now. In fact, the Accreditation Council for Pharmacy Education, the ACPE, and the Center for Advancement of Pharmaceutical Education, CAPE, both have been supporting the inclusion of cultural competence in pharmacy curricula. So starting with the standards of ACPE, the third one, in accreditation standards, a key element for the professional program of pharmacy leading to a Doctor of Pharmacy degree, which was called Approach to Practice and Care, they talk about how the pharmaceutical program should impart to the graduate the knowledge, skills, abilities, behaviors, and attitude needed to solve problems, educate, advocate, collaborate, work with a broad range of people, recognize social determinants of health, and effectively communicate verbally and non-verbally. In their key element 3.5, which was cultural sensitivity, they talk about how the graduate should recognize the social determinant of health in order to diminish disparities and inequities in access to quality care. As for the American Association of Colleges of Pharmacy, the AACP Curricular Outcome and Trustable Professional Activity, which was a revisiting and revising of the CAPE educational outcome, which was published in November 2022, they talked about cultural and structural humanity and how we can mitigate health disparities by considering, recognizing, and navigating cultural and structural factors such as social determinant of health, inclusion, diversity, equity, in order to improve access and health outcome. So what are the skills needed to be a culturally competent healthcare professional? Brown et al. Described seven.
Doctor, shall I add the poll now?
Yes, please. Please, can you initiate the poll? I totally forgot. Yes. So let's see who would know the characteristic of a culturally competent healthcare professional. So is it effective communication skills? Is it respect to other culture, being a healer, a supporter, or all of the following? So the first poll, 90% answered right. Let's see the second question for today. %, which was good. 84% answered right. So I'll be talking about, but that's a good percentage. So Brown et al. Described 7 components toward cultural competency, which has been detailed in the American College of Clinical Pharmacy, the AACP white paper, Cultural Competency in Healthcare and its Application for Pharmacy. So in the second part, which was called Emphasis on Pharmacy System and Practice. And they are as follows: to assess cultural attitude and knowledge, to learn about, understand view of diverse culture, to effectively communicate with diverse culture, to tailor treatment based on patient culture, to develop strong ties with the community, to understand national and professional care initiatives on diversity, and to evaluate progress toward cultural competency. So I'll be talking about each and every one in details now. just the moment it moves. Yeah. Starting with assessing cultural attitude and knowledge. So as healthcare professionals, we need to self-reflect on our own culture, values, and belief. We need to assess how we are viewing other culture. It's very important to value diversity and avoid ethnocentrism, in which one believes that his own culture and the way of doing things are the best. Also, we need to determine the cultural landscape of the communities we serve and acquire background knowledge about these cultures and the environment they live in order to provide quality care services. We need to learn the patient cultural factors that shape their perspective toward health, disease, and treatment. We need to know who is the decision maker of the household. So are healthcare choices individual-centered or family-centered? And we need to gain knowledge about the communication styles of different cultural groups, taking into account norms regarding social and physical distance, eye contact, communication. And we can obtain these information from the internet or textbook or becoming active in culture-specific organization, or better yet, through patient encounters, where these encounters should be viewed as opportunity for information sharing and partnership with patients and their families. An important thing to keep in mind is that generalization can help us understand cultural variability, yes. However, we should not overgeneralize because patients from the same culture doesn't necessarily have similar health belief. So we cannot make assumptions, but rather implement principles of patient-centered care. Moving forward, effectively communicate with diverse populations. So culture influence every aspect of communication, including formal greeting, eye contact, questioning, negotiating, respect, and physical distance between individuals. So as healthcare professionals, we need to assess the health literacy level of our patients and improve our communication skills, either verbally by using clear, accurate, short sentences. Also, we need to do something, which is, because we have diversity in our culture and we need to reduce misunderstanding due to language barriers, so we need to learn key terms and phrases that are commonly used by cultures in our community. Regarding nonverbal communication skills, we can employ pictograms in order to deliver medical information. And we can use also written drug information material using the languages that are commonly used by our culture. Definitely a combination of both verbal and nonverbal would be optimal. Also here, we need to keep in mind that while doing this, we need to maintain respect, accuracy, advocacy, confidentiality, objectivity, cultural awareness, and professionalism. Four would be really treatment recommendation based on patient culture, concerns, feeling, and feedback regarding the treatment in order to develop a culturally responsive drug therapy management. For example, if my patient want to take a herbal product together with his prescription med, my role isn't just objecting to this with no justified reason, but rather I need to double check if there's any drug herbal interaction or any precautions that I should warn the patient about while taking this herb. Also, culture play an important role in product selection. For example, for some culture, patients prefer to take a drug in a tablet rather than a capsule, which might contain gelatin derived from pork. Moving forward, as Dr. Sally mentioned, there are models, and there are several models that implement cultural issue into care plan that have yielded and produced positive patient outcome and satisfaction. So I'll be covering them in brief, starting with the LEARN model. So we should actively listen to our patients, explain the problem, acknowledge their concern, recommend a treat plan, and negotiate it with them. With respect model, rapport should be developed. We should express empathy and show support in order to develop partnership. We need to explain everything regarding disease and treatment and confirm that the patient understands. We need to accomplish cultural competence and establish trust. In risk model, both the patient and provider culture are taken into consideration to find resources, individuals, skills to adapt to the disease, and knowledge about other cultures. In the belief model, we have more integration of emotional factors. So what is the belief of the patient toward the health discussed? We need to explain him the health condition. We need to learn about other views, the impact of the disease in their life. We need to express empathy and know their feelings regarding their disease. Finally, we have ethnic model. As the name implies, it will include ethnic factors. So starting with explanation. So we need to explain the cause of the illness. We need to know what are the treatments that the patient's currently on, including lifestyle, OTC, herbal products, anything that he's taking at home. Number 3, is he taking the advice of a healer or a friend? We need to negotiate the treatment plan with them, intervene, and collaborate with the patients and their families. Moving to number 5, which is developing strong ties with the community, either through volunteer work or forming alliances with members of the community to learn more about the perspective, issues, and needs of these communities in order to provide services that meet those needs. Also, we need to provide additional information about broader medical care issues. 6 would be understand national and professional care initiatives on minority health. And the aim of these guidelines are to facilitate cultural competency, avoid discriminatory practice, ensure justice in the allocation of healthcare resources. We need to encourage our healthcare professionals to acknowledge and consider and respect the patient beliefs and values and practices when we are selecting and negotiating treatment plans with them. We need to allow them to take healthcare choices and integrate culturally specific habits in drug therapy. Finally is number 7, which is evaluate the progress toward cultural competency. So the question is, are we there yet? According to Health Resources and Services Administration, becoming more culturally competent can be achieved when one, define culture broadly, value the patient's cultural beliefs, recognize complexity in language interpretation, facilitate learning between provider and their communities, involve communities in identifying and addressing their needs when we collaborate with other agencies, when we professionalize staff hiring and training, and finally, when we institutionalize cultural competence. So we need to check if we are achieving all of these. That's it for me today. I want to take a moment just to express my sincere gratitude to Dr. Tabara and IVPN for their valuable invitation. It's a great honor and pleasure to be here today. I highly appreciate all the hard work and time and effort that have been invested in order to organize and host this webinar. I want to thank both of my colleagues, Dr. Sally. It was a great presentation, as always pleasure to work with you, and looking forward for Professor Murad's presentation as well. And I would like to thank everyone who took time, attended, and listened to my thoughts and ideas. Thank you.
Dr. Nasreen, thank you very much for the very enlightening presentation. I really enjoyed it so much. We'll take 2 or 3 questions, if you don't mind.
Yes, please.
We'll start with our famous IVPNeer and fan of IVPN, Majd Al-Hazar. He's saying, thank you, Dr. Arif and Dr. Murad, for the informative session. I would like to ask how we can approach a patient which has a culture belief that contradicts the way modern medicine works. Amazing question, Majd.
Thank you so much, Majd, for the question. So definitely this is a challenge, and that's why we need to, as Dr. Sally mentioned, we always work with the health belief model, and it's very good for in terms of public health, because you need to double check for your patient, would he prefer benefits? So you approach him in terms of benefit, or he's scared, so you approach him from this aspect. So you need to work your patient, know his cultural diversity and cultural, let's say, beliefs, and you work according to them. So sometimes we have patients that they don't care about themselves, but they are afraid for others. So you work on this target, and so on and so forth.
Excellent, excellent. We have a question from Ranam Hedley. Amazing first half of the webinar. Thank you, Rana. So thank you, Dr. Arif and Dr. Murad. As a student, I want to ask both esteemed speakers for tips on how students can strengthen their cultural awareness and openness prior to clinical practice. She wants to be ready as soon as she graduates. So your guidance, please, Dr. Nasreen.
Thank you so much, Rana, for being here for your question. So a very important thing is that we are currently doing this. It's definitely not all schools, but they have been integrating cultural competency in the pharmacy curriculum. So it is passed. For example, like we have a course which is professional communication, where we talk about how to communicate with patients from diverse cultures. So this would be a step before going in the field and looking at the patient. Also, we have the pharmacy practice experience courses, which is the training that students do during summer, either in the community or the hospital. And these should be viewed as opportunity to check for different patient and different perspective. And as they say, test the water and know how to deal with multiple patients from diverse cultures. So this will put you at the right position to move forward from there, and hopefully a very successful practice, as I hope.
Thank you. Thank you. Hassan Aladdin, he's saying any example from organization where they really have a good culture of diversity. Do you have anything in mind, Dr. Nasreen?
If I were to say an organization, I would be promoting, isn't it?
Yeah, go ahead. You can say IVPN, no problem.
I would say IVPN. I would say IVPN.
Thank you very much. Thank you. So with this, I would like to thank you, Dr. Nasreen, for your presence with us. Please stay tuned. Probably we'll receive more questions, by the end of this nice webinar. And now it's my pleasure and honor to introduce our Professor Abdurrahim Murad. Professor Abdurrahim is the professor at the Department of Clinical Pharmacy, College of Pharmacy at Misr University for Science and Technology in Egypt. Prof. Murad received a PhD in clinical pharmacokinetics from the University of Minnesota, USA. He has published more than 25 papers in international journals. As a consultant to foreign and local university, Professor Murad served on several education development committees. Dr. Murad established and chaired the first clinical pharmacy department outside the USA. This achievement introduced clinical pharmacy education to MENA region. And I would really honored and delighted to say that I was one of his first students at King Saud University, where Prof. Murad served as the department chair of clinical pharmacy and pharmacokinetics back in 1982, 1983, and 1984. And actually, soon after my graduation, I had the opportunity to work as assistant in his department for 4 months in the Drug and Poison Information Center under his amazing leadership. How nice is to connect with Professor Murad after more than 37 years. And I'm really delighted to welcome you, Professor Murad, to speak on my favorite topics related to effective communication. Professor Murad, I'm so happy to see you again, and the stage is yours.
Thank you, Dr. Osama Tabbara, for this opportunity. And I'd like to thank you for the invitation to participate in this IVPN event tonight. I congratulate you and your team for a valuable service that's contributing to better health care.
We can see you, Professor Murad, but
you can see me? You can see me?
Yes, I can see you.
Okay.
Just, share your screen.
Okay.
Yes, enlarge your screen, put it on full mode. Amazing. So go ahead. The stage is yours.
With a picture. A picture for the others who was shown. Yeah, really? Okay. Okay. As a professor, thank you again. I'm very proud that I saw you after 30 or 40 years. Very proud.
Me too, Wallah.
As a professor of clinical pharmacy and pharmacokinetics over the years, I have realized more and more the importance of communication and interpersonal skills for healthcare professionals. For this reason and others, I had introduced several courses and gave several lectures around this topic. My objective out of this activity is to raise awareness of the importance of good interpersonal skills. I am happy that this is now part of the curriculum at the university I'm teaching at. It became an integral part of the program. And thank you for the opportunity to share some thoughts and insights around this topic in today's webinar. The title of this webinar is Success, the title of my talk, Success in Life Through Better Communication. And I may talk about what's success. Success has no single definition. It's variable. It depends on what is the area of expertise of who is explaining success. But in general, people in sociology define success in life as financial independence coupled with happy social life. Financial independence, you earn enough to be able to support your family, and at the same time, you're enjoying a happy social life. This is the general acceptable definition of success. Researchers have reported that technical knowledge or professional doctor, pharmacist, contributes only 15% to financial success. And the ability to communicate and effectively with other people contributes 85% of your success. You can be uneducated, but you're very, very successful businessman because of your proficiency in communication. You know how to deal with human being and how to be successful in achieving your targets. So again, 85% by researchers have been allocated to ability to communicate. I will start with some basic concepts.
Professor Murad,
yes.
We can't see except the first slide. Are you going to display the slides or not yet?
Not yet.
Okay. All right.
Yes,
no problem.
Yes. I will start with some basic concepts that significantly impact the quality of interpersonal communication without really going into details. The first slide, or the second slide, this was the introduction. I finished. Next slide, the emotional bank account. Is it okay? Do you see it, Dr. Tabara? The emotional bank account.
Yes, we can see.
Okay. What's the emotional bank account? We all have bank accounts. We deposit money, and when we need money, we withdraw. We make a withdrawal. That's a financial bank account. There is another account. We call it emotional bank account, which is similar to the financial, but you make deposits. You make emotional deposits. Any person you deal with, you're opening an account with them, and immediately your account will have deposits and withdrawals. You can make deposits with any person you deal with without even attempting. by being kind, helpful, honest, apologetic when you make a mistake, forgiving, understanding. All of these make to make deposits, your credit will be high with that individual. And the level of trust will be very high. So then you have a high credit. On the other hand, if you make the opposite of these things, you're dishonest, you don't honor your promises, you're not helpful, all the opposite of what I said as deposits is a withdrawal. Withdrawals would lower your credit, communication will be hard, and relationship will not be effective, and communication will probably stop. So anyway, I brought this up to tell everybody, always be sure to make deposits. Never make a withdrawal. I do that in my life. I never make a withdrawal. I always make deposits. Deposit doesn't cost anything. It's a behavior, it's a philosophy in life. If you accidentally make a withdrawal, correct it immediately by making an apology. Say, I'm sorry. In this area of the world, we don't say sorry. We never apologize, unfortunately. In other places where I lived, like US and other places, if you make a mistake, immediately say, I'm sorry. That's normal way of life, make life easy. But here, I like people to say, I'm sorry, I made a mistake. Finished, the case is corrected immediately. So always make deposits, no withdrawals. If you make a withdrawal, correct it immediately. The higher your credit, the more trust you will have with other people, and the easier your communication will be. Next slide. Mentality of human interactions. Every one of us has a mentality when he deals with other people. There are 5 types of mentalities. I am interested in 2 of them for the sake of my talk. One of them is win-lose. The second one is win-win. There is another 3, but I'm not going to talk about them for the sake of time. A win-lose personality or a win-lose mentality is a mentality or is a person who always seek to win, regardless of any other thing. And he doesn't mind that others lose as long as he wins. This person is destructive, have poor communication, no friends. He is selfish. He hurts the organization he is working for because he's always working for himself. He always wants to be a winner. Winning here doesn't mean money. It may mean money, but it may decision-making. It's my opinion or else is what I say should be done, regardless of other opinion. That's a win-lose mentality, and it's not good, because it means he is not making use or benefiting from other people around him. I remember I attended a board meeting for a major pharmaceutical company, and the chairman of the board was a win-lose person, unfortunately. And everyone in the board would save his talk because he knows he's not going to get anywhere. Who is losing? It is the company, because people around that can contribute their thoughts found it useless because anyway, he's going to do what he has in mind regardless. So he's a win-lose person, a very bad personality. And I hope we watch for that we don't be a win-lose. We don't take it as a matter of pride, no, it is not. You're hurting the organization. Next slide. This is a win-lose. I'm sorry, I'm behind. In next slide. Back again. Yeah, win-win. A win-win is a mentality or personality where he seeks mutual benefit in all his dealings. Mutual benefit. I benefit, you benefit. I don't make you lose. But we discuss things together, and it's not my opinion or your opinion. It is the best out of both opinions. We take the best out of yours and mine, and we come out to what's called the third alternative. The third alternative, which takes the best out of both views, and we come up with a win-win solution or win-win alternative. And that's the best thing. And we should always in life seek a win-win outcome. And at home, with our children, with my wife, with my colleagues, we should always seek a win-win situation. We discuss things. You present your view, I present my view. We select whatever is best out of both, and we end up with a win-win solution or a win-win suggestion. To achieve a win-win solution, we need two characters to be able to achieve that. The first character is maturity. The second is abundance mentality. Maturity. Maturity is defined as a balance between courage and respect. Courage and respect. A person who has that balance, we call him a mature person. Like, why you call it a mature? Because he have enough courage to speak and express his view, and at the same time he shows respect to the other person. So he expresses himself and also showing respect. This is a mature person. Next slide. This is a diagram or graph that shows a diagram that shows on the x-axis, that's courage on the x-axis and respect on the y-axis. If you have a lot of courage, means you are on the right side, and little or no respect, you're gonna be a win-lose person because you have courage, but you don't respect other opinions. If we reverse it with low courage, you don't have enough courage to speak and express your views, and a lot of respect, you will be in the upper left square. You're going to be a lose-win. Definitely you will lose because you didn't have enough courage to express your views. You didn't speak, you didn't talk. And this is very common, that we keep quiet for some reason. And our quietness is interpreted as respect. And then we lose because we didn't express our view. If you have balance between courage and respect, هنبقى في الكوارتر اللي فوق على the upper quarter. and you're gonna strike a win-win. This is important in our life because we learn this at home. We learn this at home when we're children, that we have enough courage to speak. We are encouraged to speak with respect. The other way, and as a children, we're not allowed to express our views. Nobody listens. We consider talking as disrespect, and that's bad. That's why we grow up and become adults with low maturity. We don't have enough courage to express our view, and we become losers. That's how this is related to good communication and achieving a win-win. The other aspect that relates to achieving a win-win is abundance mentality. Abundance mentality is the feeling that there is enough for all of us. Everyone can have a share of what's available. The opposite of abundance mentality is a scarcity mentality. A scarcity is if I have a feeling that there isn't enough to go around, and if somebody takes a part of it, I'll have less, and that's a negative feeling, and such a person will never seek a win situation. He's going to seek a win-lose where he wins. Next slide. Empathy. Empathy is an important tool in effective communication, and it has a wide impact on the quality of communication, which is defined as sharing someone else's feelings or experience by imagining yourself to be in the same situation, or putting yourself in somebody else's shoes, or seeing the world through somebody else's eyes. This is a very powerful tool because it will allow you to see what's inside another person. I personally, when I learned about empathy maybe 15 years ago, and I started applying it, I can tell you that my personality had changed totally. Because I feel what others feel. And subsequently, I tune my behavior to their needs. So we are on the same wavelength. Communication becomes very easily. And I always give example when I go in class and I give a lecture and I apply empathy to my students in class. I look at my students and ask myself, if I'm sitting in their seat listening to the speaker, what do I want from them? So I'm putting myself in the student's shoes. I need a good lecture, clear lecture, should be able to take notes. I want to get a reasonable exam, so I pass and I get a grade. How did I know that? Because I did empathize with the students. And I always have that in mind. All the time I'm lecturing, I have that in mind. I should be clear. I should allow them to take good notes, and so on. So that's empathy. My whole life changed. Dealing with anybody, no matter who he is, I apply empathy if I'm in his position, taking care of my parents, empathy, dealing with my children, empathy if I'm 10 years old, if I'm 20 years old, what do I like to do? So empathy can change your life if you if you adopt it. I do it, and it's paying off. In pharmacy, the most effective tool in achieving patient compliance is when the pharmacist deals with the patient with empathy in mind, and the patient feels it. When you show empathy by keeping eye contact with the patient, listening attentively, responding to his verbal and non-verbal cues, showing understanding, showing respect, the outcome would be compliance to the treatment. I think I had spent enough time about empathy. It goes anywhere. Within the family, when my daughter tells me I need a pant that's like this and like that, I remember when I was at age, I always wanted to have nice looking pants so the girls would love me. So that's empathy. And I tell her, okay, you can buy it. Lack of empathy is a disease. It's a mental health or a mental issue because some people don't have empathy or cannot have empathy. Sometimes they say it's genetic or it's environmental, acquired at home when they're children. And the lack of empathy can be a result of especially how the child had been treated at home. People who feel empathy or don't have empathy have a mental disease called empathy deficit disorder. Empathy deficit disorder. It is resulting in difficulty of forming and maintaining relationship and friendship with others. Some people will have hard time having friendship with others or making new friends with others because they lack empathy, and it is a mental disease, or sometimes called a psychopath. And I had seen it, not very frequently, but they cannot empathize and they cannot evaluate the impact of what they do on others. Because if they can empathize, they should be able to predict ahead of time what's going to happen if he does this or that. And we know that emotional intelligence, if you're emotionally intelligent, that relates to empathy. And you can predict the impact of the word you're going to say before saying it. And that's empathy. I mean, if I'm going to tell you this and that, what's the impact? I can evaluate it because I'm emotionally intelligent and I decide whether to do it or not. And empathy deficit disorder or EDD person cannot do that. That's why he gets in trouble in dealing with other people. Next slide. The listening. Listening is the highest compliment when you listen to somebody talking. The most offending thing you can do is to refuse to listen to someone who has something to tell you. Very offending. So please listen to people when they want to talk to you. Another kind of listening is empathic listening. Empathic listening, when you listen with empathy, and we know already what empathy means, is putting myself in his shoes while I'm listening to him, so I'm sharing his emotions and feelings, and that's plenty for empathy. Please empathize in your all dealings, empathize. I don't know how can I emphasize it, how can emphasize this more than that. It will change your life. It will change your life. I promise you that. Now, next slide. Human characters that have direct impact on the quality of communication. Some characters can affect how good your communication or your ability to communicate are. Next slide. Appreciation. We have a deep urge to be appreciated, all humans. They love to be appreciated. If you feel appreciated, you will provide and do the best you can because you feel you are appreciated. Appreciation is a deposit in the emotional bank account. Lack of appreciation is the main reason for divorce or unhappy marriage. Lack of appreciation between the husband and wife is the main cause for divorce in the first 3 years of marriage. We love to be appreciated, so tell people you appreciate them. Thank you. Good job. Proud of you. Even if they have an average job, you still tell them, I appreciate it. Thank you very much. Good job. The impact, psychological impact of these few words will make him better. Next time, he will put more effort to improve himself, even if he's average or even below average. I do that. No matter what he does, thank you. Good job. Proud of you. Next time you will find him early on the job, doing a better job. That's appreciation. Related to appreciation is the next slide, criticism. God created us not to like to be criticized. We don't like to be criticized. If you keep criticizing me, I'm gonna hate you. This is how God made us. So don't criticize. Then the question is, how would you correct something is wrong without criticism? Yes, you still can do that. You provide guidance, not criticism. You would provide education, explanation. Let us sit down and talk about it without saying wrong. If you tell him wrong, if you tell somebody you're wrong, means you're smarter and he's stupid because he's done something wrong. No, I will never say to anybody, this is wrong. Jack Ma of Alibaba, the richest man, one of the richest people in the world, he said, we all make mistakes. Mistakes, he also said, mistakes are an opportunity to teach, guide, and advise. It is not an opportunity to punish. And the boss's job is not to hunt for mistakes. That's Jack Ma. You can search the internet. Jack, J-A-C-K, Ma, M-A, of Alibaba. These are quotes from his saying. A boss job is not to hunt for mistakes or for what's wrong. That's few words about criticism. Never criticize. Some people criticize because they think this will make things improve. The opposite's true. It's going to be worse. Next slide. Few more words about criticism. About the impact of words we say. I don't know how much time we left for.
3 minutes, Dr. Murad.
3 minutes?
Yes.
3 minutes. Okay. The words we say are very critical. Words can make or destroy somebody. If you evaluate the impact of the words before saying it, that's emotional intelligence. I do that. Takes me 1,000th of a second before saying a word to say, if I say it, what is the impact on the recipient? If it's negative, I don't say it or modify it or say it some other time or never say it. That's the impact of the word we say. Never hurt somebody else's feeling. Never. It's not your right. It's a crime in some countries. And it's also, in my opinion, in my personal opinion, it's a crime to hurt somebody's feelings. So never say a word that can hurt somebody's feelings. Encouragement. We move to encouragement. Words we say can make people do better. Never put people down. Somebody comes and asks you, can I do this? Am I be able to do that? Don't never tell him, no, you cannot, or you're not qualified, or you're not smart enough. No. In my opinion, you're killing him. You're hurting his feeling. You tell him, yes, you can do it. Even if he can't. Tell him, yes, you can do it. However, before you try to do it, you have to do this and that, or take a course or two in that area. That's the human response, and that's my comment on encouragement. No comparisons. Don't compare people. Don't say A is better than B, or tell A, you're much better than anybody else. No. You're hurting others' feelings. They're all good. They're all good. That's encouraging. Your children, don't tell you're smarter than your sister, or you're smarter than your brother. No, that's destructive. Don't do it. They're all good. Next slide. Give credit to others. If people do well, say they did, not I did. So give credit to others. I have examples, terrible examples of organizations housing thousands of high caliber people, and the boss always say he did. He writes in the paper he did. He never mentioned anybody else. People, last word, how about mental health and communication? There's a close relationship between mental health and communication. In my opinion, in my experience, many mental illnesses are related to inability to communicate. And if we correct the communication issue, the mental problem will be resolved. Lack of communication, inability to communicate is an environmental disease and an environmental issue. If you're living in a place or within a family or whatever, where you're always stressed, you're always hearing bad words, no encouragement, definitely you will end up with some mental issues, and you will reach a point where you cannot communicate. You cannot tell somebody about your ailment. You can, everything is buried in your unconscious because you don't have the opportunity to explain or talk. So anyway, there is a close relationship between mental health, happiness, love of life, and ability to communicate. And thank you very much.
Professor Murad, thank you very much for the inspiring presentation. Trust me, if we follow your advices today, we will be in much better world indeed. You know, I love the concept of emotional bank account, that we should always deposit and we should not withdraw at all. Every time we withdraw, we should deposit something as an exchange. As I agree with you that we don't have actually, we haven't lived in a culture of apology. It's very hard, especially among the new generation, to say sorry, and we need to work harder to spread a culture of apology in our region. And speaking about appreciation, we have so many messages appreciating your presentation, one from Aya Shuman, one from Wasim Abbas, saying, God bless you, Dr. Abdurrahim Murad. It's amazing presentation, wonderfully explained in terms of daily life as well as professionally. Also, we have a message from Huda Al-Madalli. Thank you, Professor, for the inspiring presentation. We really appreciate it. And also we have another appreciation from Muhammad Al-Dada, saying, I'm grateful to have been taught by such remarkable professor at Arab Academy for the development of pharmacy skills at the Arab Board of Pharmacy. Your tireless efforts, Professor Murad, and dedication to our education have truly inspired us, and I express my heartfelt thanks to you. So we appreciate your presence with us today. Due to time constraint, we will not take questions, but you know.
Would you, I'm sorry to interrupt, would you allow me to say one word?
Yes, okay, go ahead, Professor Murad.
I found out that all religions say the same thing related to what I had just talked about. If you look at one slide after the other, you can extrapolate it back to one of the religions on how to deal and communicate with other people. I did not come up with something new. And the social scientists that came in the 1900s, started 1900 with Dale Carnegie. This is a father of, he came in 1900 and came up with what they thought something new to the world. No, I would say all these things came in all religions 1,500 years ago, not 100 years ago. I just didn't want to skip saying that. All religions promote good interpersonal communication and life. And thank you.
Absolutely, Professor Murad. Thank you very much, Professor Murad, Dr. Salih Arif, and Dr. Nasreen Murad. That was an amazing event. A special thanks to Dr. Rafa Khalifa for her leadership of this event today. You know, we appreciate you, Dr. Rafa. And I will leave the final say to you before we conclude. Tfadali, Rafa.
I would like to thank all the speakers for the amazing evening. We really benefited a lot and enjoyed a lot. It was very informative, and I believe the audience, they share with me the same feelings. Thank you so much, and we hope that we see you again in our events. And special and great thanks to our mentor, Dr. Osama. I thank you for all the support and all the guidance. And thank you for all the working team for making this event happen. I wish you a great evening and great day. And thank you so much.
Thank you very much. I would also like to hear from Dr. Salih and Dr. Nasreen a final word, you know, so بتكون ختامها مسك. Dr. Salih, then Dr. Nasreen. تفضل.
Thank you so much. It's been an honor to be part of this panel of speakers. And I think just to ride on the coattails of Dr. Murad's words, we want to center humanity, no matter what position we work in, what setting we work in, what patients we work with. You have to center humanity and put aside your ego and your pride and listen. I think that's really what matters, and keep a deep curiosity about learning about others, because everyone is their own textbook. And when we start letting our ego will make us believe that we already know everything or make assumptions, then that's when we get in trouble. And that's when we stop centering humanity. So thank you.
Very well said. Thank you, Dr. Sally. Dr. Nisreen?
I just want to say thank you so much again. And I hope that from our presentation that we were able to, if we made 1% change in each and every one of the attendee, that would be great. And this 1% will be moved forward. And I hope that would be causing a change. I want to thank you, Dr. Tabale, because you are implementing amazing change all over and a totally new, amazing practice. So thank you so much. You're leading the change and with IVPN, and that's great. So I do hope that they benefit and they'll take this and move it forward with others. I hope so.
Thank you very much. I think, Dr. Murad, you want to say something and then we close. Any
Yeah, I want to say something.
Yes.
I love you.
I love you too.
I love all of you. And I love everybody. I never hated anybody, and I don't know how to do it. Honestly, even if I try, it doesn't work with me. I'm understanding, and I understand, and I give up. I understand why people sometimes get poor behavior. So anyway, I may add another thing in communication: be understanding. When somebody hurts you or misbehave, be understanding. There must be a reason behind it that we don't know about. That's my philosophy. That pushed them to do that. So anyway, I love all of you.
Thank you very much, Dr. Abdurrahim. And with this, we conclude, and have a good evening from this part of the world, and enjoy the rest of your day in the US. Thank you very much, and good night.
Appreciate you. Thank you.
Bye.
Thank you. سجلت